Good day, and welcome to today's webinar, Operative Standards for Breast Cancer, hosted by the International Relations Committee and the Cancer Surgery Standards Program at the American College of Surgeons. My name is Jessie Von Custer. I am the Program Administrator for the IRC. Before we get started, I want to inform everyone that the webinar will be recorded and will be available for viewing on the ACS YouTube page after the webinar. Additionally, if you have any questions for our presenters during this webinar, you may submit them through the Q&A box at the bottom of your screen, as there will be a question and answer portion at the end of the webinar. With that, I'm pleased to introduce you to today's moderator, Dr. Susan Lee. Dr. Lee completed her surgical training at the Mayo Clinic and Breast Fellowship at Brown University. She's the Chief of Breast Cancer Surgery at Northwell Peconic Medical Center and an assistant professor of surgery at Zucker School of Medicine. She was the first female chapter president of the Brooklyn, Long Island chapter of the ACS and was a former governor. During her term as governor, she was a member of the Governor's International Work Group. Currently, she is a member on the Commission on Cancer Education and Accreditation Committee and is also the vice chair of the International Relations Committee's Fellowship Interview Subcommittee. She has mentored medical students, residents, published articles and book chapters, and lectured both domestically and internationally. With that, I will now turn over to you, Dr. Lee.
Thank you, Jessie. And thank you, everybody, for joining us today for the ACS International Relations Committee and the Cancer Surgery Standards Program's webinar on the operative standards for breast surgery. As Vice Chair of the Subcommittee on Membership for the IRC, it is my honor to bring this webinar to the global surgical community. First, some information about the IRC. Next slide, please. So the goals of the International Relations Committee for the ACS is to provide guidance to the college's international engagement, supervise international scholarships and traveling fellowships, promote international membership in the college, and present panel sessions on topics of international interest at the Congress, and also maintain and manage the college's connection to the global community through its surgical leaders and through their societies. Next slide. So how is this done? Activities include conducting fellowship interviews for international candidates from countries without college chapters, host free webinars on topics important to the global surgical community, and some, as in this case, in collaboration with other committees of the ACS, submission of proposals to the Clinical Congress, and supporting women in international surgery. Next slide. So today's webinar is in collaboration with the CSSP, the Cancer Surgical Standards Program, and today we're going to review the operative standards for breast cancer surgery and applying and assessing and utilizing the standards in the international surgical practices. And now I am pleased to welcome Dr. Madiget Teshome. Dr. Teshome is the Chief of Breast Surgical Oncology at UCLA Health Johnson Comprehensive Cancer Center in Los Angeles, California. She completed her fellowship in breast surgical oncology in 2014 at the University of Texas MD Anderson Cancer Center and her residency at Stanford Hospitals and Clinics. Her primary clinical and research interest is in breast cancer, specifically advanced breast cancers, including inflammatory breast cancers, rare breast cancers, and surgical management after neoadjuvant chemotherapy. Additionally, she is passionate about surgical education and career development in breast surgical oncology, addressing disparities in breast cancer care, and elevating the patient voice and advocacy. Dr. Teshome is the Vice Chair of the American College of Surgeons Cancer Surgery Standards Program. Welcome, Dr. Teshome. And before we get started, as a reminder, we will have a Q&A at the end of the presentation. If you have any questions, please make sure to submit them through the Q&A box. And with that, I now turn it over to Dr. Teshome for her presentation.
Thank you so much, Dr. Lee. All right, I'm going to pull up my slides. Okay. So thank you so much for the warm welcome and introduction and for this collaboration between the ACS, CSSP, and the IRC. So I'm going to talk today about the operative standards for breast cancer. So I just wanted to take a moment to kind of think about the global burden of breast cancer. Certainly, we know in the United States that 1 in 8 women will be diagnosed in her lifetime. There are estimates that Annually, up to 300,000 women will be diagnosed with invasive breast cancer. Over 40,000 will pass from breast cancer, and there are over 4 million breast cancer survivors living in the United States. Here we can see on the bottom portion of the screen that the incidence worldwide of cancer in women is predominantly breast cancer, and that there is a high burden of mortality, particularly in many countries, as you can see here as well. So the scope of this problem is large. When we think about how we manage breast cancer, there really has been a dramatic shift in evolution over the course of the past several decades, from more aggressive surgery, such as what's depicted here, radical mastectomy, and our understanding or thinking of surgery of breast cancer as more of a surgical disease, to really a more sophisticated understanding now of breast cancer as a systemic disease, and really with multimodality therapy, a more personalized approach to therapy. We have been able to see better and better outcomes over the years. And I think one thing, though, that is key is that surgery still remains an important part of curative therapy for the vast majority of women with breast cancer. So I wanted to spend some time today just talking about the operative standards. What are they? And then also specifically to review the operative standards for breast cancer surgery, but to try to frame them within the context of what's really a rapidly evolving clinical landscape. The specific standards relate to 4 operations: partial mastectomy, axillary lymph node dissection, and sentinel lymphadenectomy, and we'll go through each of those. But really, I think understanding a little bit more about the clinical context it will be important. So I have some of that I would like to review. And then, of course, the question and answer. So I welcome any questions that you could have. So what are the operative standards for cancer surgery? So as many of you know, there have been already a lot of focus on standards in oncology and really how we can get the best outcomes for our patients. But these have mostly been focused on medical management. They've also been focused on institutional care processes. And what happens in the operation is really assumed, although we know that it can be highly variable. It's not necessarily the same from case to case or person to person. And a lot of focus has also been on the outcome metrics after surgery. For example, how many lymph nodes were resected and others. So there has been a gap or a lack of defined standards for the actual cancer operation. What are the aspects of this surgery that are going to help patients and have improved outcomes long term? And this is important because, especially for many cancers, surgery may be the only component of care that's curative. And as we know, as we just discussed, for breast cancer, surgery is an important part of the treatment pathway. So this led to the development of the Cancer Surgery Standards Program. This is the 7th cancer program under the American College of Surgeons cancer programs. And the Cancer Surgery Standards Program, or CSSP, is really focused on improving the quality of surgical care for persons with cancer. The goals of the program are to develop standards for each of the technical steps of cancer operations that we know impact oncologic outcomes, to help provide this knowledge base, to also focus on improving multidisciplinary communication by specifically through operative note documentation of key intraoperative findings, and then educating and training everyone on the team, surgeons, trainees, staff, and disseminating resources and tools to help implement these standards into current practice. So over the years, there have been 3 volumes of operative standards for cancer surgery, which have been published. And these include over 130 standards for 15 common cancers. Today, we're going to be talking about breast cancer, which this was outlined in the first volume, which was published in 2015. So when we think about surgery for breast cancer, really this is a balance of course, optimizing the oncologic outcome. That's our first priority, but then also really to ensure an excellent aesthetic outcome, as well as to improve quality of life for our patients, and to consider these as well. Throughout the phases of care, certainly we have our preoperative planning, which includes imaging evaluation, treatment planning, multidisciplinary discussion. We have what happens in the OR, intraoperative, technical details and aspects, and of course, postoperative management as well, any complications, side effects from our therapies, and also planning for adjuvant therapy. And so it's really in this intraoperative component where the operative standards are focused. And we can think of it as they're focused really on what happens skin to skin. So from starting an operation to closure. Specifically, we're looking at 4 operations here: partial mastectomy, sentinel lymphadenectomy, and axillary lymph node dissection. The volumes, the manuals then outline critical elements for each of these operations. And these are elements that have an evidence base that shows improvement in oncologic outcomes, or where there's something important to consider. And then for each critical element, there's a recommendation. The recommendation is also supported by the type of data that is driving that recommendation, as well as the strength of that recommendation, and then the rationale. So that's how the operative standards are kind of outlined. Okay, so I wanted to talk first about surgery for the breast primary. Now, when we look at how this has evolved over the past several decades, I mean, it really has been very dramatic. With our understanding of an adoption of breast conserving surgery, also more aesthetically focused mastectomies, such as skin sparing and nipple sparing mastectomy. And this has been informed by advances in breast imaging, systemic therapies, refinement of surgical techniques, genetic testing, and other aspects as well. And studies have shown an improved quality of life and satisfaction with breast conserving treatment, and also with breast reconstruction in the post-mastectomy setting when desired. And so really our goal here is, of course, to achieve the best oncologic and a best aesthetic outcome. So looking at oncologic outcomes, specifically survival, comparing breast conserving surgery and mastectomy, we know that the NSABP B06 trial, which is one of the landmark studies that really identified no difference in survival between patients treated with breast conserving surgery and radiation as compared to mastectomy. Now, more contemporary studies, and certainly not in a randomized fashion, but have started to suggest that there may be, in some cases, an improved survival with breast conserving surgery, which is interesting for us to see. And also that in some cases, even omission of radiation in selected patient populations with low-risk disease may be something that we can consider as well. But essentially, between the two approaches, there's essentially no difference here in outcome. Now, the other important outcome is local regional recurrence. And several studies have suggested, with our advanced knowledge of tumor biology and tumor subtype, that this is likely the driver for recurrence more than the type of surgery, taking into account that the extent of disease has been clearly outlined and resected. So this is an older study from 2008. It was a retrospective study of 800 patients who had breast conserving surgery. And you can see here, it illustrates that the overall rate of local regional recurrence was 1.8%, but this was highly variable when looking at different subtypes. And I also would just like to point out this was in a pre-Herceptin era, so patients with HER2-positive breast cancer did not receive Herceptin in this study. And a more recent analysis from the I-SPY 2 clinical trials outlining or evaluating over 1,400 patients treated with neoadjuvant therapy also found no difference in local regional recurrence based on the type of surgery performed, breast conserving surgery or mastectomy. But they did find an association with local regional recurrence related to the RCB class, which is the residual cancer burden. Essentially, if there was, based on the residual disease after chemotherapy, patients who had triple negative breast cancer, and patients with T3 or 4 tumors. So this also kind of highlights the fact that it's more tumor biology that is dictating the recurrence risk for patients. Another thing that I think is important to highlight is the case of multiple ipsilateral breast cancer. So there was recently reported ACOSOG Z11102 clinical trial, which evaluated patients who had 2 to 3 foci of breast cancer in the same breast that were treated with breast conserving surgery and radiation. In this study, they found low rates of local regional recurrence. The estimated incidence at 5 years was 3.1%. And one of the other key aspects from this study was that preoperative MRI may be helpful in assisting in evaluation specifically for these patients to determine the extent of disease. And then another important advancement has been oncoplastic surgery following partial mastectomy. This allows us to facilitate a more optimal oncologic outcome as well as an improved aesthetic outcome. Ideally, this would be performed prior to radiation, and studies have shown no difference in terms of local recurrence or overall survival. And in fact, typically in this situation, we may be able to resect a larger volume than otherwise. I just included an image here that shows kind of some of the different techniques of how this can be achieved, but there are courses that are put on to train surgeons in these fundamentals, and you can see that these are also provided through the American College of Surgeons at the annual meeting, and then also regionally in the US as well. So now I'd just like to focus on the operative standards for partial mastectomy. And many of these things may already be known to you as in the audience, but I'd like to review them. So here are the 5 critical elements, and I'll go through each one. So the first is tumor resection. This outlines that it's important to excise all of the gross disease to negative margins, and highlights that positive margins are associated with an increased local recurrence risk. And in some cases, this may require excision of the skin or muscle if it appears to be involved or a very close margin. Specifically, when we think about what is an appropriate margin, we have our consensus guidelines that state for invasive breast cancer, this would be no ink on tumor. And for ductal carcinoma in situ, really we should achieve a 2 millimeter negative margin. Additionally, shaved cavity margins have been shown in a randomized trial to reduce the positive margin rate. And this was reduced from 34% in the patients who did not have shaved cavity margins to 19% in those who did, and also reduced the chance for an additional operation from 21% to 10%. This, as you can see in the schematic, involves taking additional tissue from around the entire partial mastectomy cavity. The second critical element is tumor localization. Now, this is most important for non-palpable lesions. There are several modalities that are available, and so this really depends on where you practice and what's available to you and really which you prefer. This can include a wire localization, seed, which can be a radioactive seed, a magnetic seed, or others, use of intraoperative ultrasound, also the radio-guided occult lesion localization or roll. And I think that the key here is that all of these include image guidance. Additionally, we can consider bracketing for larger lesions. The third critical element is intraoperative specimen imaging. So here, what is being described is to take a specimen radiograph in the operating room to confirm excision of the malignancy and the localization device, as you can see here in the images. And probably one of the most important is orientation of the specimen. Really, I think it's a best practice that all breast specimens should be oriented by the surgeon. And studies have shown that 3-sided orientation, for example, short stitch superior, long stitch lateral, ink on the deep margin, or something like that, reduces the discordance between the surgeon and pathologist when compared to a 2-sided orientation. So many times we may not be able to take the specimen directly to the pathologist ourselves, so 3-sided orientation can help to make sure that this is accurate. And then lastly, clip placement for radiation targeting in oncoplastic cases. This allows the radiation oncologist to identify the resection cavity, especially when the breast tissue may have been rearranged to facilitate oncoplastic approach. And really, I think this is also a best practice even in cases where oncoplastics is not being performed for the same reason. So shifting gears to the operative standards for mastectomy. So here are the critical elements, and I'll just briefly review. So the first is incision placement. So as we know, there are different types of mastectomy, and this is related to if reconstruction is going to be performed or not, and there may also be other oncologic considerations as well. So with the total mastectomy, essentially, as you can see from the image here, it involves a large skin ellipse, which essentially will incorporate the nipple, the areola, and the central breast skin, and resection of the breast tissue and the chest wall flat after completion of the operation. And flat aesthetic closure has also been something that's an important advance that can help us to achieve the best aesthetic outcome for these patients as well. So that should be considered. Now, skin-sparing mastectomy, in this situation, typically we will resect this nipple and areola and preserve the remainder of the skin envelope with the subcutaneous tissue. And most of these incisions will center around the nipple and areolar complex. And you can see in some cases there can be an extension. It may be if you are hoping to reduce the skin envelope, or if you need to approach the tumor or excise some skin in a certain location. And then lastly, with nipple-sparing mastectomy, this, of course, produces the most natural appearance of the breast. And often incisions, the most, I guess, desired incision would be the inframammary incision, which you can see here in this image. Others include a radial incision or even a periareolar incision, but those can be associated with higher risks of nipple necrosis, so they may not always be preferred. I didn't include a lot in terms of indications for nipple-sparing mastectomy, but these have really expanded over the years. And certainly if a patient is a candidate from an aesthetic standpoint and there's no cancer involving the nipple, this is something that may be able to be considered. So the next critical element is related to boundaries of the mastectomy. So superiorly, this is defined as the second rib, inferiorly, the rectus sheath, medially, the lateral border of the sternum, and laterally, the latissimus muscle. And it's important for us all to remember that the breast tissue can extend into the axilla to make sure to resect all of that tissue as well. And in some cases, we may prefer to resect the pectoralis fascia, although it may not always be required. And certainly we would preserve the serratus and rectus fascia. So with the next critical element is mastectomy flap elevation. Now, this can be done using sharp dissection or electrocautery. And the subcutaneous thickness really does depend on the individual patient. The goal here is to be in the tissue plane just between the subcutaneous tissue and the breast tissue, which is an avascular plane, and helps to preserve the vascularity of the skin flap. The next element is to excise the excision of the pectoralis major muscle. Now, certainly this is not indicated in the majority of cases, but if the muscle is focally involved, then this should be considered to achieve negative margins and resected en bloc with the specimen. And often now with advances in neoadjuvant treatment, this may not always be needed as well. And then lastly is prevention of a seroma by placing a drain in the mastectomy cavity. And the main goal with this approach is to help avoid delays in adjuvant therapy, which can develop if the patient develops an infected seroma or a recurrent seroma. So now shifting gears to surgery for the axilla, I just wanted to start by talking about how this has evolved. And this has been pretty, I would say, rapid and continues to evolve. So there's always something new for us to learn in this space. So certainly we have seen a shift from axillary dissection for everyone to sentinel node staging for patients with clinically node negative disease, and even others we'll talk about. Targeted axillary dissection, or trying to better stage patients after neoadjuvant systemic therapy, and then even no axillary surgery in some patients. And this has been informed by advancements in axillary imaging, systemic therapies, or surgical techniques, as well as a shared desire among surgeons as well as patients to reduce the long-term sequelae of surgery. And so the goal here would be to minimize axillary surgery when it's oncologically feasible and safe. So this is a beautiful schematic timeline that really is evaluating or highlighting the different clinical trials that have driven our current understanding of how to manage the axilla in breast cancer. And I just wanted to briefly kind of highlight a few. So the first is the NSABP B32, which is really the foundational study for our use of sentinel node surgery in clinically node-negative breast cancer, and also outlined the decreased morbidity with this approach compared to axillary dissection. ACOSOG Z11 and the AMAROS trial are both clinical trials, randomized trials that evaluated patients who had clinically node-negative breast cancer and were found to have limited sentinel lymph node involvement, so 1 to 2 positive sentinel nodes, and then randomized patients to omission of axillary dissection or axillary dissection. And both found that equivalent outcomes essentially between both approaches. And so this really were practice-changing trials that led to de-escalation of axillary dissection in this patient population. When we think about patients with neoadjuvant, who receive neoadjuvant treatment, who were node positive and are able to convert to clinically node negative, there are several clinical trials that looked at evaluating the false negative rate in this of sentinel lymph node surgery in this setting, and I'm going to talk about them a little bit more. But suffice it to say that this allowed us to develop better operative technique to identify and stage the axilla in these patients, and also save patients the morbidity of axillary dissection when we have determined that they have had an axillary pathologic complete response. In the neoadjuvant setting as well, there are 2 randomized clinical trials that are looking at patients with node positive disease and how we should manage the axilla with surgery and radiation after based on the axillary response. So the first is the Alliance A11202 trial. We don't yet have the results of this study, but this is a randomized study for patients who have residual axillary involvement and randomizes patients to have an axillary dissection with radiation or radiation without additional surgery. So we will, hotly or anxiously await the results of this study. They'll certainly help to inform us in this space. And then the NRG and NSABP B51 trial, which was recently reported. Now, this study looked at the randomizing patients who had an axillary PCR and randomized them to receive regional nodal irradiation or no regional nodal irradiation, and essentially found no benefit in oncologic outcomes to regional nodal radiation in that patient population. And then I'll just highlight the most recent studies who also resulted that look at omission of sentinel lymph node biopsy. Now, this is very for a very specific patient population, patients who are patients who are undergoing breast conserving surgery, who have tumors that are less than 2 centimeters and have a negative axillary ultrasound, and found randomized patients to sentinel lymph node surgery versus omission of sentinel lymph node surgery, and found really no difference in outcomes. So as you can see, these studies really are helping to kind of more clearly define what is the role of axillary surgery, when it should be performed, in which patients, and highlighting the importance of patient selection, multidisciplinary decision-making, and is very nuanced. So thinking about axillary lymph node dissection, certainly this, even though we have an era of de-escalation, this is certainly still recommended in certain situations. This would be patients who have upfront surgery and who have a more significant nodal burden, 3 or more sentinel nodes, or patients who are clinically node positive. I did put an asterisk here because if a patient has non-palpable axillary nodes and appears to be a Z11 eligible or AMAROS eligible type patient, sometimes sentinel node surgery can be considered. And then after neoadjuvant therapy, certainly patients with residual nodal disease and patients with more bulky or advanced nodal disease at presentation. And then patients who have axillary recurrence, we would recommend axillary lymph node dissection. Here you see a patient who has inflammatory breast cancer, and an inflammatory breast cancer patients are always recommended axillary lymph node dissection. Looking at sentinel node surgery, really the indications for this are in the early stage setting, patients who have clinically node-negative breast cancer, or as I discussed previously, after neoadjuvant therapy in patients with limited nodal disease and an appropriate clinical response. And of course, the benefit here is that there's almost every study has shown decreased morbidity compared to axillary lymph node dissection when we think about any long-term side effects from treatment. Now, I wanted to spend a little bit of time, if it's okay, to talk about nodal surgery after neoadjuvant chemotherapy. So this, I think, is really still very critically important because it helps us to understand the response to treatment, and that helps us to understand everything for these patients. One of the benefits is to help us de-escalate surgical therapy, which I briefly discussed. Also to help us understand the patient's prognosis. So the axillary response is one of the biggest drivers of that. It helps to inform adjuvant therapy. So, in patients who have a PCR, we may be able to spare them additional therapy, and patients who have residual disease may need escalation in terms of additional systemic therapy or radiation. And it's also important for us to realize and recognize that the axillary pathologic complete response rates will vary based on subtype. Here you can see data from a large meta-analysis that shows that the patients who have the highest rates of axillary PCR are those who are HER2 positive, followed by triple negative, followed by patients with luminal B type breast cancer, and then lastly, luminal A breast cancer. And then also from data from the ACOSOG Z1071 trial, here you can see on the side, patients with HER2 positive breast cancer, followed by triple negative, and followed by hormone receptor positive breast cancer as well. So I just say all this to remind us that in this specific situation, our operations really matter. And it's important for us to really understand if there's additional disease or not, as it guides so many other aspects of these patients' care. So I'm not going to go into all the details, but there were several, as I mentioned earlier, clinical trials looking at sentinel node surgery in patients with limited node positive breast cancer, specifically clinical N1 disease, who received neoadjuvant chemotherapy. And what these studies did were all the patients had sentinel node surgery, but they all also had an axillary dissection so that it could be really clearly defined what is the false negative rate of a sentinel node surgery in this patient population. And what came from these studies is that even though when we just looked at the overall false negative rate, it was higher than we would expect or accept, I guess I should say, as our threshold, there were different aspects of the technique that drove down that false negative rate to a more acceptable value. And so this just highlighted how important our operations are, our technique are in these specific patient populations to have the most accurate axillary staging. So this included dual mapping, lymphatic mapping technique using radiotracer and blue dye, excising 3 or more sentinel lymph nodes, excising the lymph node that was clipped, which was the one that had been biopsied, and also evaluating the lymph nodes using immunohistochemistry. This is ultimately also what led to what's been termed targeted axillary dissection, or TAD, which is a sentinel node procedure with selective excision of the clipped node. You can see here in the image that there's a clip in the lymph node that had been biopsied. There's a seed that's placed next to the clip, and that helps to facilitate that lymph node to be removed. And this technique helped to improve the false negative rate pretty dramatically to 2%. The reason the clipped node is localized is because up to a quarter of the time, it is a non-sentinel node. And a more recent analysis of data from almost 700 patients treated at MD Anderson showed that about 10% of the time, this clipped node was a non-sentinel node. And in those patients particularly, 60% of the time, it was a positive lymph node, and 30% of the time, it was the only positive lymph node. So I just wanted to bring in this discussion of targeted axillary dissection refining of our technique in particularly patients with neoadjuvant treatment. And when we think about the operative standards, we would think about this as a sentinel node procedure, not an axillary dissection. Okay, so just quickly reviewing the operative standards, starting with axillary dissection. Here are the critical elements. I'm just going to review them quickly. So the first is identifying the anatomic structures of the level 1 and 2 axilla. We know that the axilla is broken up into 3 levels based on the relation of the lymph nodes to the pectoralis minor muscle. Level 1 is lateral to the pectoralis minor, level 2 posterior, and level 3 medial. The boundaries of the axilla include the axillary vein superiorly, the latissimus dorsi muscle laterally, the pectoralis major and minor muscles anteriorly, the serratus muscle medially, and the subscapularis posteriorly. The next critical element is removal of the level 3 nodes. So this is particularly not recommended. It's only recommended in cases where the lymph nodes are abnormal on intraoperative palpation. This can be because this can increase blood loss and operative time, and there's no improvement in disease-free or overall survival. So typically, we focus on a level 1 and 2 axillary dissection. We do not routinely include the level 3 nodes. The next one is removal of the Rotter nodes. These are the interpectoral nodes between the pectoralis major muscle and pectoralis minor muscle. And typically, removing these lymph nodes is not recommended unless they're known to be involved or are abnormal on intraoperative palpation. Removal of sufficient number of lymph nodes for axillary staging is also one of the critical elements, and this has been defined as a minimum of 10 axillary lymph nodes. This is an important critical element, which is identification and preservation of the critical neurovascular structures in the axilla, particularly the long thoracic nerve, thoracodorsal nerve, and medial pectoral nerves. So we can see with an injury to the long thoracic nerve, a winged scapula or limited shoulder mobility. For the thoracodorsal nerve, we can see weakness and atrophy of the latissimus dorsi muscle and an inability to do like a pull-up kind of motion. And then for the medial pectoral nerve, we can see weakness and atrophy as well as muscle fibrosis of the pectoralis muscle. Now, there are some times where the disease may involve that, let's say, the thoracodorsal nerve or the medial pectoral, and these need to be resected, but in the vast majority of cases, that would not be indicated. Next is identification and preservation of the second and third intercostal brachial nerves. So these are sensory nerves that exit the chest wall through the intercostal and serratus anterior muscles and cross parallel to the axillary vessels, really right through the axillary tissue. They do provide sensation to the skin of the medial and posterior upper arm. And if it's possible to preserve these nerves, that is preferred, as injury to them will lead to paresthesias, which can affect the quality of life of many patients. And then lastly would be drain placement, similar to in the case of mastectomy, to help reduce the risk of seroma formation and to help decrease any delay in adjuvant therapy. I did just want to mention that certainly with axillary lymph node dissection, there are long-term sequelae of this approach, and the kind of most feared of these is breast cancer-related lymphedema. And the rates of lymphedema can be quite high following axillary lymph node dissection. It's important also to remember that lymphedema can also happen after sentinel lymph node biopsy. Here you can see a schematic of the different stages of lymphedema. This is based on ICG or indocyanine green lymphatic mapping. And also this is intended to provide an idea of how these different stages can be treated with microsurgical techniques. So some of the strategies to reduce breast cancer-related lymphedema are axillary reverse mapping, which is injection of blue dye into the subcutaneous tissue of the upper arm here. And that helps to define the lymphatics that are draining the upper arm. Also lymphovenous bypass, which can be included with axillary reverse mapping, which is essentially rerouting the lymphatics into a vein to provide continued drainage. You can see here on this image, these blue lymphatics with this adjacent vein. And then de-escalation of axillary surgery. Certainly the best prevention is if it's not needed to not perform, extensive surgery or even axillary surgery at all. So our next operation is sentinel lymphadenectomy. So here are the four critical elements, which I'll just review quickly as well. So the most important is identification of all the sentinel nodes. This can be through a variety of methods. The most, standard is use of radiotracer or technetium labeled sulfur colloid. Also, you could use blue dye. That's also been widely used. Indocyanine green is also another dye that has been used, as well as the super paramagnetic iron oxide. And it's also, I think, important for us to remember that we should also be evaluating the axilla on palpation and removing any palpably suspicious or firm appearing nodes. The median number of sentinel lymph nodes which is removed is typically 2 to 3. While some patients may only have one sentinel node, that we do know that there's a higher false negative rate in that specific situation. And it's also important that the sentinel nodes are clearly identified and excised sequentially and sent to the pathologist individually and labeled appropriately. The next critical element is related to the technique for injecting the localizing tracer or dye, which you can see here in this image. There's a variety of ways that this can be performed, subareolar, peritumoral, subdermal, and others, and all would be acceptable strategies. It's also important to do a pre-incision evaluation of the drainage pattern. You can see that here in the lower picture. And this is to confirm that there has been drainage to the axillary sentinel nodes. And in some selected cases, you can also consider preoperative lymphoscintigraphy, such as a patient who's had prior breast surgery or radiation, or who's presenting with recurrence, or there can be other indications as well. And then lastly, the nodal removal technique to limit seroma formation. So whether you prefer to tie off the lymphatics, clip them, or use, cautery device, whichever is your preference. Essentially, the standard says that any of these is appropriate. So lastly, I just wanted to share some other considerations. So the first is that standardizing our operative documentation or operative notes can really be a valuable way to ensure that all of these critical elements are being performed and being documented. This can be really important, especially for our multidisciplinary colleagues, especially radiation, where it's important for them to know what we did in the operating room, and they may not otherwise unless we include it in our documentation. And, I essentially think of, in some ways, this is like a handoff, and it just formalizes this process. Additionally, I think it's important to have close collaboration with pathology. As I already mentioned, really, it's, I think, our role to very clearly communicate with them, to label our specimens appropriately, and to try to, in any way, improve that handoff with pathology, because so much really does depend on their assessment. And so that's, I think, a critically important thing to think about as well. So in summary, when we are discussing the operative standards for breast cancer, these specifically relate to the technical standards that guide breast cancer surgery and are associated with improved oncologic outcomes. They are centered around 4 operations: partial mastectomy, axillary lymph node dissection, and sentinel lymphadenectomy, and specifically the critical elements that have been defined for each of these 4 operations. So I think, while certainly I can guarantee that the operative indications will evolve as we advance in our multidisciplinary clinical care, really the indications for the operation are not part of the operative standards. I know I did focus a lot on that today just to kind of make it a little bit more clinically relevant, but the operative standards really are mostly just focused specifically on those operations and those elements. And then I think, just to put it into context, I always love this quote, which is, "Biology is king, selection of cases is queen, and the technical details of surgical procedures are princesses and princes and princesses of the realm who frequently tried to overthrow the powerful forces of the king and queen, usually to no long-term avail, although with some temporary apparent victories. All right, thank you so much. If you have more questions about the operative standards, you can feel free to reach out to us at the CSSP or take a look at the website where there's a really robust resources for you. Thank you.
Thank you, Dr. Shishomi, for your excellent and insightful presentation. By the way, Dr. Blake Cady was my mentor and certainly a titan in the field of breast surgery. And as your presentation, demonstrates, the area of breast surgery is forever evolving and it changes year by year, sometimes month by month. And just because you're able to or you can do a surgery doesn't necessarily mean we should anymore. So thank you for that. And thank you again, for all the more recent updates. And we look forward to the new standards being presented. So now with that, we will move on into the webinar's Q&A session. If you have any questions, please enter them in the Q&A now. But to start off, this presentation is for the global community, and different countries have different resources. So do you have any suggestions for applying these standards in those countries whose resources are more limited? For example, those countries that may not have nuclear medicine, access to isosulfan blue, et cetera.
Yeah, thank you so much for that question, Dr. Lee. I've been thinking about that because certainly the global audience is so heterogeneous, and as you mentioned, in terms of resources that are available, and even honestly here in the United States, sometimes that can be the case too. But I think that the kind of great thing about the operative standards are they really are centered on the operation themselves. So I think in that way, it's actually ideal for an international audience because if, you're in a country where maybe there may not be as much of an emphasis, let's say, on screening or early detection of breast cancer, maybe patients are diagnosed at a later stage, and there's a higher, prevalence of mastectomies being performed or axillary dissections, then those principles would still apply, So I think that certainly in the setting of sentinel node surgery, which would be for patients with clinically node negative disease, or like I mentioned, in some cases after neoadjuvant therapy, we are limited by the tracers that we do have available for lymphatic mapping. So in the absence of radio tracer, I think we would definitely desire to use blue dye, I would say is probably the most appropriate. And if isosulfan blue dye is not available, methylene blue dye can be used in a diluted fashion. The one challenge with methylene blue dye is it can result in skin necrosis. So that's just one thing that has to be also kept in mind. So certainly there are constraints based on what's available, but I think, as much as possible, the operative standards should hopefully alleviate that because they're really based on what operation you're doing.
Great, thank you. So we have a question here. You mentioned leaving the pectoralis fascia in certain situations during mastectomy. When is it okay to do so?
I would say that primarily that would be maybe for like a prophylactic mastectomy. I think that in most other cases, or typically the pectoralis fascia will be excised with the breast tissue. So that's how I would kind of approach that. I mean, I guess in my own practice, I routinely excise it. But that's just something that can be considered.
So in speaking with mastectomies, we often hear, and both with our fellowships have heard, it's too thin or it's too thick when it comes to the flaps. So do you have any pointers in terms of getting the flap just right?
Oh, that's such a tough question. Thank you for that one. I would be interested to hear your thoughts as well. Really, I think that I guess what I have learned or come to appreciate is that it honestly may depend patient to patient. I think that that's something that can be really important to realize. I typically use electrocautery to raise those mastectomy skin flaps. And I also think in some cases, the kind of closer to the central part of the breast or closer, of course, to the areola, it's thinner in that area. So I don't know if I have the best guidance there. I think it's also important to kind of mark out the boundaries of the breast, like even with a skin marker before you get started. That can really be helpful to make sure to kind of stay within those boundaries as were outlined. That can really help also with the aesthetic outcome too. Also preservation of the perforators, that are coming medially. So I'm curious, what other advice do you have?
So, the plastic surgeons love the flaps thicker, obviously. And I agree with you. I do tend to individualize based upon the patients because skin thickness is also variable too, rather than just the glandular part. So, and we have the luxury of having MRIs, usually some before surgery, I may look at how the glandular tissue is distributed. Some patients tend to be a little bit more central. Some, unfortunately, are closer to the skin. So that kind of gives me a little bit more of an idea. And as you mentioned, towards the areola, and this is when it comes to nipple sparing, that makes it more difficult. It does tend to be much thinner. So that
Yeah.
does help, but usually it does tend to be either too thick or too thin.
Yes, yes. But I think that I guess I would also just point out that a subcutaneous mastectomy is not really an oncologic mastectomy. So just definitely that's not something that we're doing.
Yes. So as you had mentioned, the Operative Standards was published in 2015, and thank you for bringing some of the more recent data. What may be some of the updates that we may be seeing in the more revised version or the more up-to-date version?
Yeah, thank you so much for that question. And, I am, as you mentioned, the vice chair for the CSSP, but we do have a working group that's focused on updating these standards. And I think that my understanding is they are going to be focused on kind of bringing in additional operations that are ones that we do, routinely, and trying to define as well some of these oncologic elements, critical elements that are important. So, such as I talked a little bit about oncoplastic surgery, that's like a really important area in our field and gaining, as I mentioned, more and more. And becoming more and more common. So I think that's definitely one area. Um, I don't think they will probably go back to these other standards and refine them. I should mention that in the manuals, the groups who developed these evidence-based standards, from the literature, also highlighted several kind of key questions that were important ones to consider, but where there wasn't really as much data. And so I think looking back at some of those key questions to see if there has been some more mature data would be of value as well too.
Great. Here's another question. Is there any benefit to prophylactic level 3 node dissection in those with significant involvement of levels 1 and 2?
I think that from the operative standards data, it would suggest no. It's a little bit different than maybe like melanoma or other, cancers, really level 3 nodes. We would not recommend to prophylactically excise. Certainly, if there's gross nodal involvement intraoperatively, that is something that should be considered. And oftentimes in patients with extensive nodal disease, they will be receiving radiation, regional nodal radiation. And so typically that can even definitively treat, disease in the infraclavicular, subclavicular, or internal mammary space after they have systemic therapy. So I would say the answer to that is no.
Okay. As we had mentioned in terms of limited resources, this is a question from Sub-Sahara Africa. Excellent presentation in resource limited areas where we practice with very few plastic and reconstructive surgeons and late presentation of patients. We practice a lot of modified radical mastectomies. Are there practical ways to apply these standards in our setting?
Yes, that's a great question. Thank you so much. I think that I would say yes. I mean, when you think about the standards, basically modified radical mastectomy would be taking the mastectomy standard as well as the axillary dissection standard. And I think those would be absolutely relevant and really in any setting when looking at those elements that I had outlined. I think the other aspect is without plastic surgeons, one of the things that can be considered is, a consideration towards flat aesthetic closure and really trying to, reduce any redundancy along of the skin and soft tissue along the chest wall, or, laterally and medially. And I don't want to speak out of turn because I'm not sure if they're including that in the update, but I think that would be the only kind of aesthetic technique that would be considered in the setting where there's no breast reconstruction. I hope I answered that question, but I think that certainly these still do have relevance since it's more based on the operation rather than the kind of preoperative, postoperative, or other factors.
Great, thank you for that. So anyway, for the sake of time, oh wait, I'm sorry, there's one more. Can you give a bit more detail about the possibility of better survival after breast conservation surgery compared with mastectomy?
Oh, yes. So this is really from more retrospective studies and more kind of contemporary studies. I put one of the references in there, and I'm happy to maybe if you can put your information, I can send that out to you. So I think that it's really hard to, we're never going to be able to do like another randomized trial in this space. So it's hard to be able to say that truly, but there are definitely are data that, have made that suggestion. So I think the way I kind of approach it is still just thinking about it as a equivalence in terms of survival. And, but in some cases with some patients, even talking about some of more of these nuances. Well, how
Okay.
about you, Dr. Lee?
So, with, breast conservation and with mastectomy, in, um, in resource settings, our studies, so far are showing with all the retrospective, as you mentioned, data that the survival is exactly the same. And so, as we do get more information, though, we may be able to further attenuate some of our prior practices. So we're waiting for some of the data on that.
Thank you. Yeah.
Yeah. So I think that is for sake of time. So thank you for all who participated in this webinar and all your insightful questions. It's been a pleasure to be part of this series in collaboration with the CSSP, and we look forward to future updated versions of the standards. And now I will turn it over to Jesse for final announcements.
Thank you so much, Dr. Lee and Dr. Tashom, for again volunteering your time and to share knowledge with our audience today. As I mentioned at the beginning, these presentations have been recorded and will be posted on the ACS YouTube page. You may also view past webinars under the Global Surgery playlist. Additionally, this year, residents can become members of the American College of Surgeons for free and take advantage of all member benefits. As Dr. Tashom went through some of the Cancer Surgery Standards Program Operative Standards for Cancer Surgery Manuals, more information about these manuals are on the screen, and you can scan the QR code to view that information on your phone or online. And if you have any questions about the standards, please contact the CSSP and ACS Cancer programs either through email or their social media. And today we discussed applying breast cancer surgery standards to your programs. On the screen is information for a free resource on managing breast cancer for low and middle income countries. You may scan the QR code to access this resource as well. Lastly, if you have any questions, feedback on this presentation, or ideas for future global surgery webinars, please contact me or any IRC staff. Our information is on the screen. With that, I hope everyone has a great day. Bye-bye, everyone.
Thank you.